Right. Good evening. I will start this session by introducing myself and thank you for joining the session today. My name is Colin Nnadi. I am a spine surgeon. My NHS practice is in Oxford and my private practice is at the Portland Hospital in London. And this is where I am today as I've been operating all day. My main interest is pediatric spinal deformity, scoliosis in particular, and that will be the thrust of this talk. So I can see there are already a few questions from Rakshanda Sadiq, which says, when to have surgery for scoliosis correction? Well, the decision to have surgery is usually a joint one between yourself and your specialist, and it all depends on how rapidly and seriously the curve has progressed. So most curves don't require surgery, but then there is a minority that do progress sufficiently enough to need surgery to stop them. So you'd need to be assessed by your specialist who will get x-rays and maybe some scans to then decide if surgery is indicated. So it's usually a joint decision. So if there's anything else you'd like to ask about that, but I hope that's answered that question. So I suppose whilst we wait for other questions to come through, in terms of your specialist and the decision making, there is a certain magnitude of curvature you expect to see that then helps the decision making process as to whether surgery might be indicated. And the cutoff is usually 40 to 45 degrees. So if you have a Cobb angle, which is the measurement of the size of the curve, if it's more than 40 degrees, you can then start to think about surgery. So surgery isn't always required. Some people don't mind that they have a curvature of their backs and are happy to live with it, particularly if in a child that stopped growing, then there's a very small chance that the curve will progress, and then surgery therefore isn't always necessary. Now there's a question that's come in which I was expecting, which is, what's my opinion on VBT? That's vertebral body tethering. And for those of you who haven't heard of it, it's a modification of an old way of treating scoliosis surgery. So scoliosis surgery, in principle, can be treated either from the front, where you make an incision through the chest wall, or you go through the back, or sometimes you can do both. Now, historically, the aim has always been to fuse the spine. The downside of that is that it then inhibits growth. So in a lot of young people, there's often a conflict between having a spinal fusion to treat scoliosis, which on the one hand corrects the curvature, but then on the other hand stops growth in that part of the spine that's fused. So recently, some of my colleagues in America have come up with this system called vertebral body tethering. And it's essentially operating on the spine through the chest, putting in instrumentation, but not fusing the spine. So instead of fusing the spine, they're putting screws in and then connecting those screws with a strong cord. And the idea behind that is that it preserves normal movement as well as correcting the curve. Now, it's a very interesting technique, and I think it's still early days. There are studies going on, but the truth is, nobody knows in the long term what the results will be like. The posterior fusion, although it does have the disadvantage of stopping growth in that section of the spine, it is a tried and tested technique that's been done for years now, and we know it works well. So although the vertebral body tethering procedure is an exciting prospect, we still don't know enough about it to recommend it to the wider public. And I know that certainly NHS England and NICE have reviewed all the evidence available, and their feeling is that on the current evidence they cannot recommend it as a mainstream treatment for scoliosis. But who knows, in another 5 years or so, if the results of some of the ongoing studies start to come out, then that view may change. Okay, a patient of mine actually says, my daughter was due to have surgery next month with myself, but this has obviously been cancelled. My question is, now she is 16, will she have to go onto the adult ward? Not necessarily. At the John Radcliffe, I think the cutoff is 17 years of age, so she may still have to go to the children's ward. But then sometimes if we feel that the 16-year-old is able to cope with being on an adult ward to get their surgery done, then we have a discussion, and if both sides are happy with that, then yes, we can do it on the adult ward. The next question is, there are mixed reports about trampolining before and after surgery. What would your advice be? My daughter has an S-curve of 69 degrees and 70 degrees and currently is wearing a Boston brace whilst waiting for surgery. So I think before surgery, it's certainly okay to do that. I think anything that keeps the spine flexible, such as exercise, is a good idea because it then helps the surgeon get a better correction. Now, in the immediate aftermath of surgery, so I would say within the first 3 months, it may be a bit difficult to do that. And then even after the 3-month period, if you are to start trampolining, you need to be careful and often have it done under supervision. You certainly won't be able to do any backflips on the trampoline. Next question is, how will my flexibility be after my fusion? I'm 37 and have a 55-degree curve. Well, it depends on the part of the spine that's fused, but generally the part of the spine that's fused won't be flexible anymore. You will be able to exercise, but there will be restrictions because of the stiffness. Next question, is 49 degrees likely to progress and get worse? Age 15 now, thanks. Well, that's on the borderline. So the natural history studies have shown that if you have a curve of over 50 degrees and above at skeletal maturity, then there is a chance that it will continue to progress. So 49 degrees is on the border, but yes, it could progress, but at a very small rate each year, so about 1 to 2 degrees. So do you recommend removing rods after growth stops? No. Unless they're causing problems. So next question is, I've had 3 children with a fusion, happy to share experience, that would be fine. Next question, I've been getting a lot of pain in tail of my back. It now hurts to sit. Is this because of the curve? No, I don't think so. I think that's an entirely different problem, and it's usually called coccydynia. In answer to the last question about exercise afterwards, someone's kindly chipped in and said, yes, you'll be able to. I was 15 and went to surgery with a 78-degree curve. I was an acrobatic gymnast and I'm still able to run, swim, act after recovery time, and also do handstands gymnastics. You've just got to be careful, yeah. So that's just reiterating what I said earlier. So the next question is, my daughter had corrective surgery age 13 and she was able to do trampolining afterwards. And then someone said, could you talk about individuals who have had spinal fusions in pregnancy? Can you have a normal birth, epidural, anything else to consider in terms of fusions and pregnancy? So I think the main issue with a fusion and pregnancy is that you need to make your obstetrician aware that you've had a fusion, because depending on the level of the fusion, having an epidural might be difficult, or even in some cases, if the fusion's gone right down to the base of your spine, impossible. There's no reason why you can't have a normal birth, but the main issue is having an epidural afterwards. But otherwise, it has no impact on a normal delivery. So someone said, so I've had spinal surgery 11 years ago and my scar is still numb. Is this normal? Yes, it is. Because when you make the incision over the back for the scar, you actually have to go across the cutaneous nerves. So the scar runs downwards, top to bottom. The cutaneous nerves run across, and you inevitably damage them. In some people, the numbness gets better over time, and in others, unfortunately, it doesn't. So someone else has said, I'm fused with a single rod and wires. 30 years later, I'm falling apart. Now what? My curve is back to 40 degrees. Well, you need to see your specialist and get up-to-date x-rays and then discuss what the treatment options may be. Someone else said, there's a lot of debate on whether scoliosis causes pain before having surgery. What's my opinion on this? I was in pain before my surgery, but was told it wasn't to do with my scoliosis. Well, ordinarily, if it's an idiopathic scoliosis, in other words, there is no underlying cause, because most cases of scoliosis, or the commonest types that we see, are the idiopathic ones, then you shouldn't have pain. You may have muscle ache because of the curvature of the spine, but you shouldn't really have debilitating pain. And if you are, that may be indicative that there's another problem going on. And your doctor should ask for an MRI scan to look at whether there are any other issues going on. Next question is, if a Harrington rod is fractured, does it need removing? Well, if it's causing symptoms, yes. If it's not, then it's perfectly reasonable to leave it alone. Someone said, I am T2 to L3 fused. That may be the questioner about pregnancy. Then that should be good enough to allow you to have an epidural. So someone else said you had a fusion 6 years ago this year and the scar seems to have moved. Is this normal? Well, it may be indicative that there has been further progression of the curve. So I would get it checked out with an X-ray, or it may just be due to the fact that you've grown and your body shape is different. So let's see. Someone else operated on. Thank you very much. So I'm 7 years post-spinal fusion surgery. The fusion is the full length of my spine. I have an overhang and mechanical pain. I know physio is the answer and do this daily, but still get a lot of pain. I was just wondering, do you have any other advice for this? Yes, you should see a doctor. You probably need an MRI scan to see if there is any degeneration around the fusion that could be causing your pain. Someone said, what do you think of magic rods and the LASIS field safety notice? I have been heavily involved in the magic rods right from the outset, and I've published quite a bit on the rods. So I think they're, one of the greatest inventions to be used in pediatric spinal surgery in the last decade. But I think, like most of these devices, they're not perfect and they do have their issues. But I think it's only with research and time that they will get better. But at the moment, I don't think there is anything else that compares to them in terms of reducing the number of surgeries and providing an overall better quality of life. So I have been involved in the field safety notice discussions, and I think it can only be a good thing if they're being looked at and ways of improving how they work are being thought about. So I have no problem with that. I think that's a good thing. Next, can you have an MRI scan with a Harrington rod? I've often wondered, as I believe it's metal, I had it done. Yes, you can, but it may distort the quality of the images. But you'd have to discuss that with your specialist. So I was fused from T2 to T12. Is it a worry that the bottom part of my spine may continue to grow and need more surgery in the future? So that depends on how old you are. If you're still growing, then yes, that may happen. If you're now an adult, then that's unlikely. So as I mentioned earlier, my oldest daughter is awaiting surgery for a curve. My youngest daughter is now waiting to see a consultant. As I know, AIS is prevalent sibling. What is the exact prevalence? Should we be too worried? And is there anything we can do to help in the meantime? I can't quote any figures off the top of my head, but yes, it can run in families. And if you are worried, then you should see a specialist. And the easiest thing to do is, although it's difficult in teenagers, is to look at the back. And if they get her to bend forwards and look for any asymmetry of the upper part of the back, if you're worried, then take her to see a specialist. Next question is, how much on average would you say that a spinal fusion costs to the NHS, including paying surgeons? It's interesting to know. Well, the first thing to say is surgeons don't get paid for doing scoliosis surgery on the NHS. We get an annual salary like any other employee and don't get any separate payments for scoliosis. The cost to the NHS, well, I would say the cost in the region of anywhere between £30,000 to £50,000 per patient. Does the NHS offer much in the, whoops, that's gone, sorry. I'm post-fusion, 25 years, my Harrington rod is fractured, will it need removing? Well, again, if it's symptomatic, it may do. If not, then there's no harm in leaving it alone. Next is my 14-year-old daughter who's 9 months post-op, 14 to 13, she's a dancer. When is she likely to be able to jump when dancing, please? At 14 months, 9 months, she should be fine to do that now. Next is, if fusion causes further degeneration, particularly below the rods, why is that fusion is the gold standard of care? Why has nothing really been done over the years to find other treatments? It feels like with fusion, further surgery is likely, and we are setting patients up for pain act. No, I think the fusion is the gold standard because that has been shown to be the best way of stopping further progression of the curve. There has been a lot of research over the years in trying to find ways of treating scoliosis without having to fuse the spine, but unfortunately, that remains the best way of stopping progression. Historically, when the spines weren't fused, the treatments often failed. So unfortunately, there's nothing new in the pipeline. We'll just have to wait and see what VBT does. And not everyone, there are lots of patients who've had scoliosis fusions who go on to lead perfectly healthy and normal lives. I noticed on a Channel 5 TV program showing a spinal fusion that bone graft was no longer taken from the hip area. Is this now common practice? I had a spinal fusion in 1978 and I sometimes feel tight, achy in the area where bone graft that was taken. Is this why it may no longer be done? Yes, you're absolutely right. They used to take bone graft from the top of the hip, but that's no longer done. In fact, I've been operating today on a patient and I didn't take bone graft from the hip. I simply harvested it as I went along. So it's very, very rare to do that now, to take it from the hip. Next question is, my son is awaiting surgery but has been postponed for COVID. He has had tedious smile 3 as well. His back has progressed immensely in the last 3 months. His specialist has been emailed pictures, and we just have to wait until surgery can start again in Devon. But my worry is his spine has rotated. What can you advise? In the meantime, it's no harm in getting a physiotherapist to look at his back to help with exercises and flexibility. Because anything you can do to increase the flexibility between now and when he has surgery would certainly be very useful. I'm having a fusion on my thoracic spine, but I have degenerative disc at L4-5, and there's now talk of operating on both at the same time. Would this be best? It's difficult to answer that question without a proper examination and a look at your scans. Sometimes it does make sense to do that because if you stop short of an area of serious degeneration, then that only predisposes more or further degeneration in the non-operated area. So it may be that your surgeon has taken the view that it would be best to incorporate that now. But like I said, it would be very difficult for me to comment without actually having seen your scans or examined you. My daughter is under you at Oxford and is waiting for magic rod surgery. We haven't seen a physio for over 10 months. She started to complain of pain, especially in her back and hips. It's genetic. She also has Chiari and other issues. She's not very mobile. Well, it would be worth speaking to your GP about organising physiotherapy for her, but I think that would be helpful. Unfortunately, with the COVID situation, we haven't restarted our elective paediatric pathway yet, and it may be a few more weeks. So I would get in touch with your GP to organise some physiotherapy, or if you're really worried, make an appointment to see me in my clinic, and we'll try and sort things out for you. Do we have any further information about genetics? It is more likely that my child could get scoliosis because I have it. So in terms of genetics, I actually wrote a chapter for the American Scoliosis Research Society on genetics last year, and no, there hasn't been any new evidence come through about the genetics of scoliosis. So all we know is that it can run in families. So if you've had scoliosis, then it makes sense to keep an eye on your child to see if she develops it. So what's the largest degree angle you have ever treated? 150 degrees. I have mild scoliosis. Do I need it checked? A scan showed but docs have not said anything. I only found out when they asked for medical records. Well, if you're an adult, then doesn't really make a difference. It's unlikely to get worse. Although, if you did develop degenerative arthritis in your spine later on in life, then yes, it may cause problems. But if it's a mild scoliosis, then I wouldn't worry. Before having a child, are there any tests that can be done to determine likelihood of the child developing a scoliosis? No, not to my knowledge. Do you have any idea of how far behind the surgeries that the JR is now? I would say our waiting times used to be 4 to 6 months, but I would say they're well over that now, but I couldn't give you any exact figures. Next, my daughter has the magic rod since December 18. My daughter still suffers with a lot of pain and discomfort. Is this the norm? No. So if she's getting pain and discomfort, then we need to find out why. So you should see your specialist. She needs an X-ray. Sometimes the screws used to anchor the rods to the spine can loosen. Sometimes there can be a low-grade infection, and you can only tell what's going on with further imaging in the form of X-rays or scans. Sometimes you don't find a cause. Is it common to have SI joint problems years later? No, it is not. Also, are there less complex surgeries performed at the Nuffield rather than the JR? Yes, there are less complex surgeries performed at the Nuffield. Discectomies or disc herniation, excision, spinal decompression surgery. So yes. Right. So I think it's gone quiet. I'll go back. So I'm sorry if I haven't been able to answer everyone's questions. I'll just try and go through as many of them as I can. My daughter has Williams syndrome and other underlying health issues. She's had the Schiller growth rods inserted, then corrective surgery 5 months later at the JR. The rods are doing their job, absolutely amazing. We are now waiting to hear when she will be fused. Is there a specific age you fuse the spine? She's now 13. Well, it's roundabout now. I would say 13, 14. Sometimes with the Schiller rods, you can actually leave them in. And if they're not causing problems, then you don't need to convert to a definitive fusion. In response to pain after magic rods, thank you. She missed her 3-month review due to COVID, but I'll take your advice and meet with consultants. Good. My daughter had fluid. My daughter had fluid on her spine when we had the cardio appointment before lockdown. Is this something to worry about? Not quite sure what you mean by fluid on her spine, but it sounds to me like you need to speak to your specialist about that. Carol Grace, can you have a Babel normal after rods? Yes, you can. What's your view on spontaneous fusion? My daughter has had the traditional growing rod since age 2. She's now age 14. Her spine likely fused around age 10 when we stopped getting them. She has a very short torso and a curve of around 50 degrees, which is 98 degrees of surgery. Do you think there's likely to be anything medically that can be done to help her? So one of the reasons why the traditional growth rod stopped was because of spontaneous fusion of the spine. Because of all the surgeries required, there's a higher risk of spontaneous fusion. Now, when this has occurred, there are surgeries that can be done, but they're usually very big operations that are not without risk. So I would advise that you have a chat to your specialist to discuss what the options are and whether you would like to go through with any of those. Is traction still used? Yes, it's one of my favorite procedures for the really severe curves. So I will often use it to increase the flexibility and stretch out the spine in a very severe case before actual surgery. So my daughter had an operation when she was 13, she's 22 now. Should she have any regular checkups? I'm asking as a concerned parent whose daughter doesn't really keep them up to date. So all I'd say about that is if she has any symptoms, then yes. If she's doing well, then it's not really necessary. So if there are concerns, then yes, get her checked out. There seems to be a correlation between dancers and gymnasts being diagnosed with scoliosis. Is there any scientific evidence for this, or is it that it's more noticeable because of, it probably is because of what they wear? I don't think there's any scientific evidence linking the two. Sorry, I'm into scoliosis surgery form enough, but rather than the JO where there are no other complications. Yes, in some 16 or 17-year-olds where apart from the scoliosis, they're otherwise fit and healthy, yes, then it can be done at the Nuffield, but not during the COVID period. So is bracing still different as a treatment for adolescents? What is the rate of success for this method? So bracing is still offered. In terms of success, it depends on the compliance. So the more compliant the child is, the better the results, but it doesn't work for every child, and it doesn't treat the scoliosis, it just controls it. So my daughter had a spinal fusion 2 years ago. So far her recovery's gone very well. The screw to the bottom of one rod looks as though it may have moved, cannot see the endoscope on X-ray. It's not giving any problems. Do you think this will be okay long term? Difficult to say. She may develop pain. If it does become a problem, then see your specialist, because sometimes the screw may need to come out. It's not a big operation, and I'm sure your specialist can sort it out. Is there anything that's an absolute no-no after 6 years post-op? No problems at all since op. I would say the one thing I do advise is not to do things like bungee jumping, or to be careful with fairground rides, but otherwise just enjoy your life. My daughter had fusion at age 13. She had a lower curve left in fuse, but my daughter still feels pain. Could this be why? Again, it's one of those scenarios that's difficult for me to comment on, as I don't have any x-rays and I haven't seen your daughter. But if you do have any concerns, then please see your specialist. The least she would need is an x-ray. What's the approximate stay in hospital on spinal fusion, on thoracic spinal fusion on L4-5? And also, what is rough recovery time for both of these for someone in their 30s? My job is desk-based, so I'm worried about this. So again, difficult to say. Generally, with the younger patients, the length, I'm getting my length of hospital stay down to 3-4 days in hospital, but that's for children. For the adult patients, it's usually longer. So for a scoliosis operation, I'd expect about a week. For an L4-5 fusion, I would expect a couple of days, 2 to 3 days, but it can vary from person to person. So next question, do you have to have rods put in, or can you leave it? She is 42 degrees. Again, that would depend on the clinical appearances. So 42 degrees is kind of borderline, but there would have to be an examination and an appreciation of what the extent of the clinical appearance is before a decision can be made. And it also depends on how much it bothers her. So is it still done lying down? This is about traction again. So there are two ways that it's done. So generally, so the children that I put in on traction are generally very young. So I have a specially adapted wheelchair that I use so that during the day they can get around, but with the traction still on. And then at night when they're in bed, the traction's on. but it can be taken off to allow them to shower and things like that. So the answer is no, you don't have to lie in bed permanently. Should you expect to have more pain in your back and hips as you get older? Yes. Fusion at 15 and now 43, but struggling with more back and hip pain each year. So this could be as a result of the fusion, or it could just be the natural aging process. Although at 43, you are quite young. So I would go and see your specialist to get some more investigations. So next, I had my spinal fusion almost 3 years ago now, and I have two screws slightly popping through my skin towards my neck. It causes pain from time to time. Is this something to worry about? I think you need to see your specialist and get some more imaging to see what exactly is going on. Are 16-year-olds treated as adults? My daughter is 16, was due to fusion now, but now delayed. She's desperately worried that she will be classed as an adult and therefore on an adult ward where I am unable to stay. I think it depends on the hospital. Some hospitals, depending on the maturity of the 16-year-old, would be happy for them to stay on a children's ward, or in some cases on the adult ward. So, but I think it's done on a case by case basis. My daughter now has an airway alert because of her Schiller rods being high up. Will her airway improve when she has her fusion? Again, it's one of those questions, unless I have the facts before me, it's difficult to answer because I'd need to see her x-rays to know what exactly has gone on, how big her curve is at the moment. So I can't really answer that. So given boys don't seem to be as affected by scoliosis as girls, in your experience, is there any difference in surgical outcome for teenage boys versus teenage girls? I would say the main difference in outcome is that the girls seem to just get on with it better than the boys. The boys tend to stay in bed a lot longer. My daughter had metal rods at 16, a curved scoliosis. The surgeon hoped the top curve would self-correct. It hasn't. She's now 26 and gets some sciatica, but otherwise okay. Should she be strengthening her back in any way through exercise? Well, daily exercise is good for you, no matter what you have, and particularly as she's had scoliosis surgery previously, it is important that she maintains her physical fitness. So yes, I'd say she should continue with exercises. Next, my medically complex 8-year-old has a 75-degree upper curve. How early can she have a fusion? Her surgeon wants to avoid magicals due to potential complication. She seems pain-free at the moment. She's non-verbal and has repaired. So 75 degrees is a rather big curve. She's a bit too young for a definitive fusion. She's only 8, and I would suspect that she is also slightly smaller in physical size than her peers. So I don't know, it's a difficult one. I don't know what the exact circumstances are, but that curve needs to be prevented from getting any bigger because the consequences are long-term respiratory and cardiac problems. So there are different options. It's not just the magic rods, but I think there has to be a balance between allowing the curve to get bigger and these consequences associated with that and the risks from surgery. So I think you need to have a chat with your surgeon about the treatment options. Thanks so much. What is the general recovery time of a spinal fusion in an adult returning to work? So I normally say expected stay in hospital 7 to 10 days. Takes 2 weeks for the wounds to heal. It takes you need, if you're in employment, you probably need 2 to 3 months off work. And then full recovery in an adult takes the better part of 12 to 18 months. Is 10 too young for fusion in a complex needs 2? Again, it would depend on what the circumstances are in terms of clinical examination. So there are lots of factors taken into consideration when deciding whether to fuse or not. So the size of the child, the average height in the family. So I always look at the parents, to give me an idea of what the expected growth is like. You also need to look at the child, and you also need to look at all the other medical problems and to decide whether it's in their best interest to have a fusion or offer a growing rod construct. So that again is based on a case by case basis. Do you see many people who've had Harrington rods when younger who now experience back pain? Not as many as you'd expect. So the Harrington rods, I think the same way the Harrington rods revolutionized the treatment of scoliosis is the same way that the magic rods revolutionized pediatric or early onset scoliosis. And the downside of the magic rod, of the Harrington rods, was that they just corrected the spinal deformity in a single plane. So, there were complications like what's called a flat back deformity, or the hooks would pull out. And so they went out of favor. But considering the perceived problems, we don't actually see that many people coming back asking for more surgery or coming back complaining of problems. So next question. My daughter is 9 and just had a scan and MRI. She has a 19-degree curve, which has grown 5 degrees in 5 months. Should she be braced sooner rather than later, as if it's changed quite quickly? She's keen, James. So 19 degrees is still fairly mild. So it's progressed 5 degrees. So if there's further progression, so between 20 and 45 degrees, you can either observe or you can brace. So I would say if there is further progression at the next checkup, then yes, it would be reasonable to consider bracing. So does surgery improve? There's no such thing as a daft question. So does surgery improve the rib hump as well as the curve? Yes, it can. But I always say to patients that surgery won't get rid of the rib hump. It will certainly make it look better. And it's the same thing with the scoliosis. I always say I won't give you a perfectly straight spine, but I'll give you a better looking spine such that if you walked into a crowded room, no one will know you had scoliosis. So my daughter is 15. Do you have to be do you have to be a certain weight to have rods? She's only 7 stone. Well, obviously, the more average weight you are, the better you are likely to withstand the stresses of surgery. And then there's also the risk of having prominent metalwork if you're underweight. And the upshot of that is that can put pressure on the skin, and you can have metalwork breaking through the skin. So yes, we do like that people are of an adequate weight and health status before surgery is done. So how many hours a day should my 12-year-old daughter ideally wear the brace for? We've had 3 different answers. She's had it for 1 month. So ideally, it should be 23 out of 24 hours a day, every day. But one has to be realistic and say that a 12-year-old girl isn't going to want to wear a brace for that long. So I always come to a compromise and say, well, 20 hours a day, you can take it off for exercise, or if you have any particular games you want to play, take it off for those and then put it straight back on again. Not always, it depends. Handle on shoulder, which improvement after surgery. Sorry, could you explain what flat back is and what complications it brings? So flat back it's a terminology that mainly came from using the Harrington rod. So like I said earlier, the main disadvantage of the Harrington rods was that the correction was basically in one plane. So all it did is an S shape when viewed from the side. So the flat back is when whichever part of the spine has had the rods applied is flat, and that disturbs the normal spinal posture and can lead to back pain, early degenerative arthritis in the spine, and usually needs quite big and complicated surgery to sort out. But we're now more aware of this, so surgeons take more care during operations to make sure that they don't disturb the natural shape of the spine. So hello, I'm 23 and I have double major scoliosis and I got surgery to correct my top curve. They said the lumbar curve was complementary and would correct, but in the 2.5 years since my surgery, my lumbar has already progressed again by 15 degrees since then, and I keep going, and it keeps going up. Will it stop eventually? We're certainly discussing surgery, but I'm curious. Thank you. Yes, it may continue to increase. It depends on what the baseline size of the curve is. So the natural history studies, again, the natural history studies talk about what happens when you don't do anything. So in the thoracic spine, if you have a curve at maturity of 50 degrees and above, that is going to get bigger, albeit about 1 to 2 degrees a year. In the lumbar spine, the number is 30 degrees. So curves of more than 30 degrees after maturity may continue to progress. So this is something that I think you need to discuss with your specialist about how to manage. So yes, there is a risk that it could continue to get worse. So another question, my 16-year-old daughter has idiopathic scoliosis awaiting surgery. My 18-year-old niece has a 20-degree curve. I don't have it, but at 50, I now have degenerative arthritis in my spine. Could there be a connection? Not really. If you haven't got a scoliosis, then no, it's unlikely. I think the degenerative arthritis is a separate issue. Also, my 13-year-old son has a curve due to one leg being slightly longer than the other. He's seen by it. Does the leg length discrepancy tend to even out during growth? He is going through a rapid growth spurt now, so I'm watching him like a hawk. Well, that's good. So it depends on how much of a leg length discrepancy there is. So most people will have a leg length discrepancy. Anything up to 1.5 centimeters is acceptable and usually is not treated. Anything over that, I think the pediatric orthopedic surgeons would advise simple things like shoe raises, adjustments to. Sorry, I'm just in the piece of paper. Yep, sorry. Yeah, sorry. Would shoe raises, adjustments to foot heights or inserts and things like that. And then in severe cases, surgery could be considered. But yes, you should watch it like a hawk. Okay, my son has low stakes SM83 and scoliosis, and he only weighs 6 stone and is awaiting surgery. Does this weight go against surgery? He would need to be assessed by your specialist, a dietitian, and a physiotherapist and occupational. So the decisions around whether to operate or not are usually taken as part of a multidisciplinary process. So as a scoliosis surgeon, my concern, and I have treated patients with Loeys-Dietz syndrome, would be if they are physically small and I were to put metalwork in, then how likely is it that A, the metalwork would be prominent, and B, would put the skin at risk from breaking down after surgery? So I think there has to be a detailed discussion with your specialist and other members of the team to make a decision about whether surgery is appropriate now or whether he needs further nutritional support before considering that. So I don't know if there's any more questions. Right. So if there are no more questions, I could perhaps wrap up now. And thank you to all those who've taken part and your questions. And I'm sorry if I didn't answer everybody else's questions. And I'm sorry that I'm in my theatre scrubs because I've just come straight from theatre to do this. But hopefully we can have a few more of these sessions, and it increases your understanding of the condition. So I've got one more question. What are your views on revision surgery with people with flat back syndrome? Again, I think there needs to be a two-way discussion between the specialist and the patient. It really depends on how the flat back affects your quality of life, and also on the experience of your surgeon. So it is big surgery, and it involves performing what's called an osteotomy, which is where you break the bone and realign the spine. So it's not a simple procedure. So, gosh, there's lots of questions. So, you need to think very carefully and have a detailed discussion with your surgeon. Next question is, how long can a lengthening be delayed? So it depends on what device is being used. So with the magic rods, particularly around COVID, a lot of my patients have been delayed by about a month, and I think you can get away with a month, to 6 weeks. But anything longer than that, then you need to have a discussion with your specialist. My daughter has lumbar curve at 76 degrees, was due surgery in March. How long is it okay to wait before it gets too large, given COVID? It's a really difficult question to answer. A 76-degree curve, if I had my way, would be operated on yesterday. But unfortunately, the current circumstances don't allow us to act as quickly as we would like to. So I think you need to have a chat with the unit that's looking after your daughter. My daughter had a fusion, but is developing a new curve below the fusion. What degree curve would require surgery? Again, it depends on what the x-rays show, so it's difficult for me to answer, but you should speak to your specialist. It also depends on whether the new curve is causing imbalance or truncal imbalance as well. So Heather, I have two 90-degree curves. Would you recommend surgery? I'm also almost 40. Yes, even if it was just to stop the progression of the curves, because at 90 degrees, I would be worried that they'd start to affect your breathing and heart function. So you don't always have to have complicated surgery, but you could have surgery that will at least stop those curves from getting worse. Right. So if if people don't mind, I need to go and see the patient that I've just operated on to make sure they're well. But thank you for your time, and I look forward to speaking to you again sometime. Thank you very, very much.